Okay. Good evening, good afternoon. Thank you very much for your attention. We're bang on past, so we will get started. Welcome. My name is Fergus Dobal. I'm one of the stroke physicians and geriatricians from Edinburgh. And this is Joanna Wardlaw, Professor of Neuroimaging, Brain Imaging, also in Edinburgh. And we've put together a program today that we hope you find interesting. Now, we have two audiences here. We have the audience in the room, but we also have a large audience online, and I hope I'm looking at the camera now. Please forgive my acting skills. Better at being a doctor than an actor, you'll be pleased to know. We have some housekeeping rules, and so I suppose I say welcome to the Royal Society of Edinburgh. We're thrilled to have you for this event as part of the Curious Festival of Knowledge. We have a fire and safety and evacuation procedure. If something happens like a fire alarm, don't panic unless you see anybody else panicking, and then tell them not to panic. We need to go outside and congregate outside the dome, so that's out to the road, and turn right. The fire exit routes are on the current slide, but if something happens, you should follow the Curious staff's instructions, and they are waving at the back of the room, and they're wearing purple. So follow anybody in purple just for this afternoon, not in general life. We have a couple of other sort of, I suppose, basic housekeeping things. We have several short presentations and segments. We do not have questions after each segment, but we have a big question session at the end of our event today. There are several ways that you can ask us questions. You can ask us online, and we will collect them and respond. If you're in the room, you can either write it down on a piece of paper. You should all have pieces of paper to do that. Or when the time comes, you can put your hand up and we'll try and get to you. And we'll work through all the questions that way. If there are questions we cannot get answered, we will answer them and put them on the Brain Health Arc website. It should be on all the agendas as well. So every question should be answered. So don't worry if you're not if you're not picked. That's not quite the right word. If we don't get around to your answer here. We have lots of information sheets and leaflets that's out in the foyer in the left. There will be a half time. I always get told off calling it a half time at the theatre and stuff. I'm not quite sure what the other word is, but there's a half time break in the middle of this event. So we've got 15 minutes for comfort, etc. And I suppose the final thing to say is timing is very tight. I get very nervous about timing and overrunning. And so I've got two cards. So if you follow football, either when you're asking a question or to the speakers, you'll get this card first and then this card if I'm very, very nervous. Okay. And that's just about it, really. In terms of the topic, we're delighted, and we've been quite excited, actually, to put this together. And it's lovely to be able to talk about the role of blood vessels in causes of vascular dementia. So I think it's an area that we'll be able to focus on to try and help us find treatments for dementia. So in terms of an overview, I'm going to invite Tim up to the stage. Tim Wilkinson is a neurologist from Edinburgh who runs memory clinics and will be talking to us in general about the field.
Great. Good afternoon, everybody. So yes, as Fergus says, my job is to give a little bit of background to set the scene. I'm going to talk about blood vessels and dementia. I'm very conscious that a lot of these words I'm going to talk to you about and define, you'll probably all have heard of before. But I think it's important that we set the scene properly and make sure everybody is talking about the same thing. It will make the rest of the afternoon make more sense. So when we talk about mild cognitive impairment, or MCI, this is a slightly nebulous concept, but what we mean is somebody has memory or thinking problems that are there, but they're not sufficiently severe to affect their daily life in any way. So their function is the same as it would have been anyway. Some people with MCI just stay like that forever, and some people, their symptoms can get worse, and if they start to get impaired, then we call that dementia, and that's just the difference between the two. So all dementia means is somebody has a thinking problem, be it memory or something else, that has reached a level now where there are things in life that it's difficult to do. Their function is impacted in some way. That might be washing and dressing, but it could be cooking, doing your finances, driving. And you can imagine that differs for different people. And we're here today to talk about dementia. And probably we wouldn't be here. I think everyone in the room thinks that dementia is important. And we all have our reasons for why we think dementia is important, but it's important because it's common. So about 1 million people in the UK have dementia, and it's now the leading cause of death in this country. It's important because it's expensive. So the UK spends £25 billion a year on the health and social care costs of dementia. But of course, it's really important because of the impact it can have on the person with dementia and their loved ones. And that's the real reason that dementia is important, and the reason that I think I speak on behalf of everyone saying why we are interested in this from a research and from a clinical point of view. Alzheimer's disease is one of many causes of dementia. And if you read the textbooks, it will say it's the commonest cause of dementia, and I'm going to come back to that. So in Alzheimer's disease, 2 proteins build up in the brain over years, even decades, causing first mild cognitive impairment and then dementia. The textbooks say that vascular dementia is the second commonest cause of dementia. So vascular just means blood vessels. And that could be because someone's had strokes, or it could be problems with the small blood vessels in their brain that we call small vessel disease. And small vessel disease is a subject that's probably been neglected historically, and people like Professor Wardlaw, who you introduced to at the beginning, has done more than anyone in progressing this field, helping us to understand what these changes mean. But in the brain, we have these tiny blood vessels that go deep into the brain, and if they get damaged or blocked or leaky, they can start causing changes that we can see on a brain scan. And if they get bad enough, they can start causing symptoms, and that might be walking problems, mood or behavioral problems, or cognitive problems with dementia. And I think it helps to visualize this. So I'm going to give you a brief radiology tutorial and show you what it looks like, what small vessel disease looks like on a scan. So when I'm seeing a patient in clinic and the report says they have small vessel disease and I bring up the scan, this is what I'm looking at. I'm going to talk you through it. So to orientate you, imagine you're at the feet looking up through the body. So that's the right and that's the left. It's counterintuitive because we're looking from the bottom up. And we've taken a slice across the head so we can look at the brain from the bottom up. And just to orientate you to the level, you can see just the ears on the side there, the nose, the bottom of the eyes. So that we're down towards the bottom of the brain. And as I'm scrolling, we're just taking slices moving up through the brain. And you'll start to see some black spaces in the middle of the brain. And those spaces are where the spinal fluid is made and then absorbed. They're supposed to be there. But around the edges of the spaces, you'll start seeing these light grey, fluffy changes. You see that? So that's small vessel disease. That's what we're talking about. So that's these little blood vessels that are building up. And as I said, if they get severe enough, they can start causing symptoms. So that's what they look like on a scan. I said that the textbooks say that Alzheimer's disease is the commonest and vascular dementia is the second commonest cause of dementia. It's not quite true. Most people have what we call mixed dementia. So most people have more than one cause of their dementia. When they've done autopsy studies where they've looked at people's brains after they've died, people who had dementia, most people have more than one pathology, and most of the time that's a combination of Alzheimer's disease and the vascular changes. And the interaction between those two is really complicated, and we're still trying to understand more about that. It seems to be that these Alzheimer's proteins and the blood vessel changes interact together in a negative way, impacting someone's cognition, and we're still trying to understand how that happens. So to summarize, I've told you that mild cognitive impairment is where someone has cognitive symptoms, but they're not affecting their daily life, as opposed to dementia, where their cognitive symptoms are now impairing their function in some way. The commonest cause of dementia is what we call mixed dementia, usually due to a combination of Alzheimer's disease and vascular dementia. And a really important cause of vascular dementia is damage to these small blood vessels in the brain. And the reason we're here and the reason that we're interested in vascular dementia is actually this is potentially a very important area in terms of what we can do, because in theory, some of this dementia should be preventable and treatable. And we'll hear a bit more about that as the afternoon goes on. Thank you.
Thank you very much, Tim. It's lovely, lovely to see brain images. Now, In Edinburgh and Glasgow, there's a reasonable amount of research and clinical activity going on in this field. And it's important to hear from healthcare professionals, but it's even more important to hear from people with lived experience. So at this point, I will introduce Terry Quinn, who I think will introduce Willie and Donna as well. Terry Quinn is a professor of old age medicine through from Glasgow. Over to you, Terry. Thank you.
Fergus, and thanks to everyone for coming along. It's really great to see you all. So I guess if we think about what we're trying to do this afternoon, one of the things we're trying to do is break down silos. You know, these artificial distinctions we make between things that are actually more common than we think. So the first silo we're breaking down is on the M8. I came here from Glasgow to Edinburgh. That's allowed to happen. Another silo we want to break down, sometimes. Another silo we want to break down is this distinction that doctors are very guilty of making, of thinking that dementia is one thing and other problems with blood flow to the brain, like stroke, is something completely different, and there's no connection between them. And hopefully by the end of this afternoon, you'll see there's really quite a strong connection between them. The final silo that we want to break down is this distinction between a medical expert or a research expert and the other people who really have expertise, which is people who have lived through a stroke or a dementia diagnosis, people who are experts by their lived experience. And what we want to do in the next 10 minutes is just speak to two people, and I'm very pleased to introduce Willie, who's here, who's lived through a diagnosis of dementia, and Donna, who's here, who has had a diagnosis of the stroke in the past. So welcome to both of you. I wonder if I could just start off by asking each of you, could you tell us just a little bit about yourself and a little bit about your story? I wonder, Donna, if you want to start.
Hi, I had my stroke when I was 46 years old. I was a very busy mum, mum of 2 children. I worked in a very high pressure job. I was overweight, I smoked, sedentary lifestyle, total stroke waiting to happen, but that wasn't what caused my stroke in the first place. It was a coronary artery dissection. So I had my stroke and then went through all the hospital procedures, blah, blah, blah. Everything was fine. But immediately when I had my stroke, I'm all about medicine. I love anything to do with medicine. So I was asked initially, as I was getting my brain scan at Southern General, could they use that for research? And I was like, yeah, carry on. And then was asked back a month later to help with stroke research. So I did that. I do a lot to do with stroke research. I've lived... It's been hard, don't get me wrong, because you get the emotional part of it. I was very lucky because I was thrombolised. I didn't have any major defects or deficits until my second stroke, which was caused by a PFO. That's left me with visual impairment, which is the worst thing ever because I had to took my driving licence off me. And I keep bumping into things. But I get a lot of memory issues. Last night I was cooking the dinner and I had a jar of curry paste in my hand. And then I wanted to use it later on and I couldn't remember what I'd done with it. 10 minutes later, I'd thrown it out, but I'd forgotten about that. Just wee simple things like that. And then I do a thing where if I'm looking for something, I could be looking straight at it and not actually see it. It's very strange. Anyway, that's me.
Thanks, Donna, and thanks for coming along. Willie, do you want to...
Yeah, so my name's Willie. I'm aged 71. I was diagnosed with a form of Alzheimer's disease 3.5 years ago. I say a form of Alzheimer's disease because Alzheimer's disease most generally starts in the hippocampus, as at the back of the brain. Mine is in my parietal lobes at the top of my head. I have a SPECT scan. SPECT scans are very exciting. You get pumped full of radioactivity, then told not to go near small children for 2 weeks. It's really very odd. In my SPECT scan, my brain shows as yellow, and there are 2 dark blue blobs where you can literally see that blood isn't flowing through my parietal lobes. So the one thing everybody knows about Alzheimer's disease, it affects memory. My form of Alzheimer's disease doesn't affect my memory. It does affect my verbal working memory. So if you give me a list of numbers, I might well give you the numbers back, but perhaps not in the right order. But my visual working memory is fine, and my episodic memory, so what happened last week, I can remember that. But I do get interference with my eyesight. So I see things which don't exist, not in terms of hallucinations, but in terms of, how do I describe it? Dots and dashes that are generated not by my eyes, but by my brain. And that's quite hard to come to terms with.
Thank you, Willis. I think what I'm getting from both of you is you have one diagnosis, and if you're reading a book about stroke, for example, you'll hear about people with a weak arm, a weak leg. But people can have these diagnoses and present in very different ways. Now, Donna, you mentioned problems with mood and also problems with memory and thinking. I wonder, did anyone talk to you about those things when you had your stroke diagnosis?
Not when I had my diagnosis, no. I had to ask for referral to clinical psychologist, so I worked through that with him. That was one, but not straight away. Nobody mentioned anything about it. Although I read all the Chest, Heart and Stroke Scotland leaflets, big advocate of Chest, Heart and Stroke Scotland. They had leaflets all over the hospital, so I read every single one of them. They touched on it then, but it was more the emotional. I mean, I was always quite emotional anyway, but after my stroke, I would be watching something on the television, and it was quite sad, and I would be tears streaming down my face and sobbing. I mean, never done that before, but it was really extreme what was happening to me. Even after, maybe 5 years later, there was the advert for Oxo or something like that. It was about the dad and the teenage daughter, and that really got me. The first time I watched that, I was lit in bits, and my partner was just looking at me as if to see what's going on there. But he's lived with it as well, so he knows what's going on. He knows how bad I can get.
And Willie, you'd mentioned that with your dementia, one of the problems you have is with eyesight. And again, people might think, well, eyesight, that's an optician, that's got nothing to do with dementia. Were visual problems ever mentioned to you?
Nobody mentioned these problems to me. What happened was I lost sight in one eye for a few minutes. I thought, this is a bit odd. Went to my optician's because I was starting to see a kind of blob at 4 o'clock in my left field of vision. She showed me on a retinal camera where it showed up and sent me off to the eye pavilion, who took a retinal scan and then said, Mr. Gilder, there is no problem with your eyesight. And I said, but I've seen a picture. And they said, well, all we can suggest is there was a fleck of dust in your optician's camera. And it was almost chance that the consultant was reading through my notes and said, we see you've been to a memory clinic. And I thought, I've never been to a memory clinic. What's a memory clinic? Because I hadn't been to anything called a memory clinic. So it was happenstance, really. And when I talk to people about what I now know we can call cognitive visual impairment, they all go, never heard of that. That's a bit weird. But that's the way these diseases go.
And actually, you touch on a really important point that we're going to cover later this afternoon, which is sometimes when you have a condition that presents in lots of different ways, you can end up at Clinic A, Clinic B, Clinic C, and they can sometimes feel a little bit fragmented. I don't know, Donna, has that been your experience if you think about some of those problems you mentioned, with mood?
With my first stroke was fine. All the clinics that I attended were appropriate. With my second stroke, they didn't diagnose it. One consultant said it was a stroke. The other consultant, who was initially under, said it wasn't a stroke, because I had happened to mention that I'd had a hormonal headache, so he put it down to menstruation. It was a menstruation headache, and that's what caused the episode. But I still had the loss of vision. I've got no peripheral vision in both eyes to my left side, so I still had all that. So I was sent to outpatients, the clinic there, and it was a optometrist who actually diagnosed that it was a stroke, because I still had it 4 months later. Nobody in the stroke ward or anybody said it was a stroke, but it's because it had been going on for so long, and that was frustrating because I wasn't referred on to anybody else. It was just the optometrist said it was a stroke, and that was it.
And Willie, how about you? What's been your sort of journey with your symptoms?
A friend of mine last week summed up diagnosis for people with Alzheimer's as diagnose and adios. And pretty much that's been my experience. I was diagnosed, That's almost the last conversation I've had with any medical professional about my brain disease. I've talked to my GP about lots of other things since, but never about Alzheimer's. There is no treatment, so why would anybody bother to talk to me?
How do you feel about that?
Furious, actually,
Yeah.
for all kinds of reasons. I feel that in the main, we accept that people with strokes are given rehabilitation, but we seem to accept that people with dementia are left. Now, I know that there are therapeutic interventions that you can do with people, probably not pharmaceutical interventions, but social interventions.
Yeah.
I've used music very effectively to help me. But I think there's too many people who are just falling through the gaps and not getting the help that they need and deserve.
Yeah. I mean, I would completely agree. And I guess if I may, Willie, and then Donna, if we could change things, what would you like to see change, Willie? I wonder if I could ask you first.
If we could change things, I would like the medical world to accept that there are many interventions that we can make with people living with mild cognitive impairment and dementia that aren't pharmaceutical, they're not pills. They might be meeting a peer support group, they might be listening to personally meaningful music, but actually research demonstrates that these are very effective interventions, probably more effective than the current new wave of drugs whose names I can't pronounce. That's what I would change.
And Donna, it sounds like you've had good and bad in your experiences with healthcare. If you could change something.
If I could change something, I was part of a focus group for stroke. One of the fellow participants had the same experience as myself, that she had a visual impairment as well, and she didn't get any treatment. So she was a very intelligent lady and did something along this lines, and she was speaking to a room full of medics, and she told me that she asked the medical people in the room how many realise that you can have a visual impairment from stroke, and hardly anybody rose their hands. So it's just a case of getting everybody to understand and realise that it's not just like the fast symptoms. There are other symptoms that indicate people have had a stroke, and visual impairment is one of them.
Yeah, and I think particularly for this afternoon, for this room also, problems with emotions, problems with memory, problems with thinking could be part of that.
Yeah.
So we've got lots of researchers in the room. We've spoken about how you might want to change clinical services. If we could do some research, what do you think are the important questions? I wonder, Willie, do you want to go first?
Yeah. As I say, the one thing everybody knows about Alzheimer's disease, it affects memory. Actually, Alzheimer's disease affects all sorts of things. It can affect, but my very first symptoms were a lack of empathy and allied depression. I then had these various different cognitive aspects. I think we should be doing more to research those areas. When I talk with other people with the same disease, actually it turns out that most people have got some kind of experience of some sort of sight difficulty. If you read the literature, you won't find that. And I think it's because memory kind of so dominates the thinking that people haven't paid enough attention. So, listen to the people with the disease.
Yeah, and I think you've hit the nail on the head, Willie, that when we think about this thing called dementia, we think of memory, and we maybe aren't as cognizant of all of the different other ways that it could present. So Donna, how about you? If I gave you a blank cheque, you could fund any research you want. Obviously, I'd want it to come to me, but what would you like to see?
Ideally, in an ideal world, I would like to find somebody who can do research that I can get my sight back, that I can get my driving licence back. That's a bit selfish. But again, everything that Willie said. The other thing I have, which is I don't have a filter, which is a big thing. So looking into the emotional side of and the cognitive side, and the emotion, and then again, as I said, speech. I've got absolutely no filter, so excuse if I happen to say a sweary word later on. I'm apologising now. It just comes out. Got it in there first. Yeah.
So I think what I'm hearing from both of you, and this wasn't scripted at all, but I think it proves the point. We think of dementia, we think of memory, but actually it can present in so many different ways. We think of stroke and we perhaps think of weakness down one side, but again, it can present in so many ways, and the after effects can present in lots and lots of different ways as well. So, I mean, I think it falls on me just, again, to say thank you for sharing with us. Thank you for letting us know some of your story. You're both going to stay with us this afternoon. You're not getting away. You're going to be part of some of the other sessions. But I wonder if we could just thank Donna and Willie for their contribution to this session.
Brilliant. Thank you very much. That was just superb. As a quick follow-up, I cried at the OXO advert too. A lot of empathy there. Okay, so we're now moving on quickly. One of the problems, and we've heard it brilliantly illustrated actually, and that was totally unscripted, so I can't believe how appropriate that was. That if you have problems with the blood vessels in your brain, you can present in many different ways to different healthcare professionals, optometrists. They seem to be the popular one this afternoon. And one of the next session is going to look at which clinics and how patients can present to medical services in different ways. So you've already know Terry, and Terry's going to team up with Una Clancy, who's a geriatrician from the Royal Infirmary of Edinburgh, with a special expertise in stroke, small vessel disease, and the emergency department, which is a interesting area too. So over to Una and Terry. Thank you very much.
Yeah, okay. So thanks very much, Fergus. So my name is Una Clancy, and as Fergus mentioned, as well as being a researcher, I'm also a consultant in geriatric medicine. So I look after older people who come into hospital acutely unwell, and that's both in the emergency department and in the wards, but people can come in with all sorts of different problems. And Terry, just tell me a bit about what you do.
So, again, I'm a clinician, I'm a doctor as well as being a researcher. If you want my full title, I'm the Professor of Cardiovascular Aging. But I think what that tells you is problems with blood vessels are really important to a lot of the conditions that older adults have. And a lot of the research that I do, as well as a lot of the clinical work I do, is looking to try and make things better for people that have blood vessel problems that then cause lots of other symptoms.
Okay, so tell us about this, Terry.
So, behind me is the elephant in the room. I want to just tell you a little bit about this story. It's a fable that is actually across cultures globally, and it's a story that tells of wise men, experts, who were blindfolded and taken to the desert to an elephant. And each of them were asked to feel one part of the elephant. And they were asked, what is this thing? What are you feeling here? And you can see, it's nicely illustrated here. This person here feeling the leg of the elephant says with complete confidence, I'm feeling the trunk of a tree. And this person here that's feeling the trunk says with absolute certainty, oh, I'm feeling a spear. And the person up here that's feeling the elephant's ear is saying, I'm feeling a fan. Now, you might well be thinking, Terry, why is he talking about an elephant? You know why am I talking about an elephant?
Yeah, why are you talking about an elephant?
I'm talking about an elephant because what we see here is something that Willie and Donna alluded to earlier. People that are specialists in their own area sometimes don't see the whole picture. They perhaps see the visual problems, but don't see that that's part of a wider brain problem. They perhaps see the emotional problems, but don't see that that's part of a wider brain problem. And what Una and I want to try and do is just show you how that can be so very true for people that have problems with blood flow to the brain.
Yeah, so individually, the blind men, they've all got some idea of what's going on, but in its entirety and as a whole, they've not got this holistic approach or this whole big picture view to be able to diagnose this as being an elephant, which is a metaphor for dementia here.
So you've heard a little bit about Una's background, my background. I mean, we have the privilege that we work in lots of areas. We all work in the A&E and in an outpatient clinic and in the main wards. So we see people at lots of different stages in their journeys. And I think to maybe illustrate the point that we want to make here, we'll maybe just look at a couple of patient stories. So let's start calling some people up onto the slide. So here is the first person. I'm having to crane my neck a little bit to look. But the first person here has came to the emergency department, the A&E. And it's because they've made a bit of a mistake with their medicines, and that's probably because their memory and their concentration and their ability to manage their medicines just hasn't been so good for a while.
And this woman is worried about her husband's memory, and she's dragged him along to the GP to get it looked into. And often family members can notice there's a problem before patients do.
And here we've got our next person who, again, is having bother with medicines. Medicines are complicated. You know, trying to remember when to take them and the different combinations, it's a tough ask. And you can see this lady here is really starting to struggle with remembering when to take different medicines.
And this patient has got acute confusion on a background of more chronic problems with thinking and memory. And again, here's someone whose family are concerned, and they're highlighting this problem to healthcare professionals.
And the last person we have there is someone that has had a stroke, but as a result of that stroke is now struggling with memory and thinking and all of these other things.
And so these are all very different stories, and they've all presented to different healthcare settings with different problems, but they're all potentially linked by problems, such as problems with blood flow to the vessels in the brain. And the link that all of these people share, so Bruce Willis and Margaret Thatcher and Rosa Parks and Barbara Windsor and Ronald Reagan, is that they all have or had a diagnosis of dementia. So while they have a unifying diagnosis, the stories for these people that led to that diagnosis were very different.
And you get full marks if you recognised everyone in the pictures, because I didn't recognise Rosa Parks. So before you came this afternoon, you may well have thought, if you have problems with memory and thinking, you're going to go to a single doctor, a single clinic. But hopefully you're starting to realise that that's not often the case, and particularly where your problems might be due to blood flow problems to the brain. Because the brain does so many different things, that can present in lots of different ways, and you can end up going to lots and lots of different services, and they're sometimes not as joined up as we might like. All of them are important, and I don't want you to take a message from this session that the clinics aren't useful, but we just wonder, could they be a little bit more joined up?
And so if you do go to one of these healthcare settings that's listed here, and you feel that your problems aren't being heard, it is important to say so, and it is important to advocate for yourself and to get yourself to the right clinic. So if you think that's the memory clinic, you should really be an advocate for yourself. And even if that means speaking to the healthcare professional to ask them to signpost you in the right direction, or if that means going to your GP if you haven't got an answer that you're satisfied with, then we strongly encourage you to advocate for yourself and get yourself to the right clinic.
So we were interested in this area, both Professor Wardlaw's team in Edinburgh and my team in Glasgow. So we thought we wanted to have a look and see, well, what are the different ways that blood flow problems in the brain can present? So we took information from 500,000 people that contributed to a research study, and we looked at those people that had blood flow problems to the brain, and we looked to see what were the different ways that those problems manifest themselves. And you can see on the slide here that blood flow problems to the brain aren't just memory problems, aren't just emotional problems. We've got problems with sleep. We've got problems with physical activity. We've got problems with the heart system. So really all across the body, because of all of the things that the brain can do, if the blood supply to the brain isn't working as it should, those symptoms can come in any of the different systems.
And so you can see how someone might end up going to lots of different clinics, or maybe not the right clinic that's dealing with memory problems per se. And so you can see how problems with blood vessels in the brain cause more than simply just brain problems, and they can cause problems throughout other parts of the body and manifest in lots of different ways.
So we're back with our old friend the elephant now. Hopefully, without labouring the point, you now see why this fable actually tells you a little bit about how clinical services are at the moment, with people working in their own little bubble and perhaps not seeing how things are connected.
So hopefully we have empowered you, a potential patient, to speak up for yourself and to advocate for yourself, to be that information link that puts everything together, because you know yourself and your relatives better than anybody. So if you do have concerns about your memory, your thinking, your mobility, your mood, or any other symptoms that might be related to blood vessel flow in the brain, do seek advice, and do get yourself to your GP, get yourself to the right clinic, and advocate for getting your problems all seen to in the right place.
Yeah, I think that's absolutely right. That's the message that we want to bring across. When we gave a title to this session, we called it Clinics Can Help, and they absolutely can help. But just because you went to one clinic, if you feel they've not completely covered all the things that are troubling you, please do voice that, because doctors won't know unless you tell them.
Thank you.
Thank you.
Thank you very much, Una and Terry. That was fantastic. My daughters would tell me that the 10 wise men couldn't work out what it was because they weren't 10 wise women, would be my only mild comment. Thank you very much. So we've heard that one can present differently to different specialties. We're here to talk about the future and treatments as well. And I'd like to invite Professor Will Whiteley up to the stage, who's going to talk to us about treatments for vascular dementia, what we have, what we haven't got, and what we are hopefully going to have in the future. Thank you, Will.
Thanks very much. Welcome. Lovely to speak to everybody. So if I was going to talk to you about the treatments for vascular dementia, unfortunately my talk would be quite short. What I'm going to talk to you about instead is to think about where these new treatments are going to come from, and roughly how scientists think how to discover new medicines. So how do we think about finding new treatments for all sorts of conditions? And really, when we look at the treatments in use today, there are three ways in which they've been found. The first way is a really deep understanding of the physiology or biology of the condition. The second way is looking at conditions that already have a treatment that look a bit like the treatment you're treating and use those medicines. And the third way is actually by chance. There are plenty of medicines where discovery has been made by chance. So for understanding the physiology of vascular dementia, we're going to need to think, I'm going to explain to you a little bit about what the blood vessels do in the brain and how we might think about changing the way they work. If we're going to think about treatments that can be used to treat similar conditions, well, let's think about some medical conditions that are similar to vascular dementia. Well, Alzheimer's disease is different but similar. Stroke, we know, is a risk factor for vascular dementia, different but similar. And we might look for treatments for other conditions we know increase the risk of vascular dementia, like diabetes. And all of these types of conditions, similar medicines are being studied. And the third way is by chance. That's very hard to do in dementia, but has been done, has been found for a number of conditions over the years. So let's think about what blood vessels look like and how we're going to treat them. So first of all, if we look at the blood vessels that flow to the brain, blood flows from the heart through the large arteries, the internal carotid arteries, that then supply larger arteries within the brain, and they have a particular physiology. And those those arteries are affected by the same kind of processes that increase the risk of heart attack and ischemic stroke. So that's one way, looking at treatments for those conditions, that we might find treatments that work for dementia. Each of those large arteries branches into small arteries, and each of those small arteries are surrounded by smooth muscle. They're surrounded by other cells called pericytes, by other cells called, and then form this structure called the blood-brain barrier. And all of these cells might well be things we could target to treat dementia. And the third place we could try and target is the brain damage that results from low blood supply. So the brain itself is affected by low blood supply or by leakage of parts of the brain, and perhaps we could do something to try and reverse those changes. So those 4 areas are where people are looking particularly carefully to target new treatments. How can we do this? What kind of methods do we use to find new treatments? Well, the first one, if we're trying to find new treatments, is we would be looking at animal experiments. And animal experiments can examine the effect of drugs, can examine the effect of genetic changes or on diet, on things like blood vessels, on brain tissue, or the expression of different genes or different proteins. And they have the advantage that you can do these experiments quite rapidly. You really can deeply understand the mechanism, the way in which these drugs work. And because most of the animals that are experimented on don't live for a long time, you can look at how they work over a significant proportion of the animal's life. But they have significant disadvantages, which is that, of course, the animals that are usually used, mice and rats, they're not human. They're very different. Their brains are very different than human brains, and they develop no dementia. The second way we can try and find treatments is to use genetics. Many of you, or some of you, may be parts of studies like the UK Biobank, Generation Scotland, Our Future Health, and each of these studies has been set up to try and look at the effects of genetics on the risk of diseases of aging. And what it's possible to do now is use genetics to try and mimic the effects of drugs, so you can study what you think the effect of drugs are going to be in a large number of people. And the advantage about that is we can then use those to see the effects of what drugs might be on dementia, on brain scan changes, memory changes, or even developing dementia. And that has the advantages that you can do these experiments quite quickly. They're definitely done on humans. The problem is that those types of information is really only available on large populations like largely white populations in the UK. It's very difficult for us to look at more diverse populations from different ethnic minorities. And the last way we can do that is by doing experiments with humans. And that way we can really see what the effect is of the drug in a person. The problem is those experiments can't be so long, so we can look at changes using scans or changes in blood tests or changes in memory, but it's very difficult to see if we can look at the risk of dementia in long term very quickly, because dementia takes a long time to develop. They're also highly regulated, so they're very expensive to do. So these are the 3 ways that most of us as clinical scientists would think about developing new drugs, and people are looking at these in vascular dementia. But there are plenty of medicines that have been tried, and each bubble is a medicine that's been tried in a clinical trial. Up in this study to 2016, there are many more since. But unfortunately, none of these medicines actually have a significant impact on the risk or the progression of vascular dementia. But fortunately, there are 2 new candidates which don't make it to this diagram, which Professor Wardlaw is currently testing. So why has it been so hard to find drugs that work for dementia? Well, I think that there are really, our fundamental problem is that we need, we've got a better understanding of dementia than we ever did, but we don't really truly understand why some people get dementia and others don't. And that means it's difficult to identify the real targets for treatment, and it's really hard to know which things we should measure as we're testing medicines to look at the effect of medicines on dementia risk in the shorter term. Lastly, as we've had mentioned before, many people who develop dementia in the real world have more than one cause of dementia, so any treatment against any one type might only have a small effect. Thank you, that's all I had to say.
Thank you very much, Will, and thank you to the other speakers. So we're running pretty well on time, so my stress levels are not off too bad at the moment. A couple of quick reminders. Please do ask questions on the pieces of paper or think about the questions you'd like to ask, and we'll have a panel of experts up here later to answer them, so please do get them to us somehow. We now have a 15 minute break. For those online, we will be resuming in exactly 15 minutes' time from wherever we're at now. He says, having picked up his phone that he's just turned off. So in 15 minutes, we will resume. Could you just join me in thanking all the speakers and those who have taken part? Thank you. Okay, thank you very much for coming back. That's great. I'm always a bit nervous giving people a break that you can run away, but thank you for coming back. That's fantastic. Just a very couple of quick comments and welcome to the online group as well. We had over 100 for the first session online only, plus all of us in here. So we're delighted to be reaching so many people, and we really hope it's interesting and informative. We now have a section led by Joanna Wardlaw, who you met earlier on and who's been referenced lots of times so far. We have a panel of experts here, so from left to this side to that side. I get muddled up depending on which way I'm facing. This is Katie Gallagher, who's a GP through from Glasgow. Again, we're friends with people from Glasgow, lots. Okay. Carmen Atiaja Reyes, who's a neurologist from Mexico working with us in Edinburgh. Terry, you know, and Donna, you know already. I didn't say you were from Glasgow. Okay. And just to be, she's from Ardrossan in Ayrshire.
Don't mention the ferries.
Thank you. So over to Joanna now. Thank you.
Well, thank you very much, and thank you again very much all for coming. And it's great to see so many people here and also online. So we've heard a lot about the, if you like, more medical aspects of cognitive impairment and dementia. And this panel discussion is going to be a bit more about what can we, as individuals, do to try and reduce our risk of dementia and also to reduce the risk of progression of dementia if we have any symptoms. And this is really about trying to maintain your brain health, as it's increasingly called. So this slide summarizes a number of the brain health messages which we are now bombarded with, and you'll be familiar with them from NHS, but also many other countries have similar brain health messages. There's a number of do's down the left-hand side. These are more about lifestyle choices. There are a number of things in the middle which are more about things that would require medical interaction, diagnosis, and then down the right-hand side, we have a number of things which you should, generally speaking, try and avoid if possible. And, you know, at the moment, there are up to 14 different modifiable risk factors, as they're called, that can help to reduce the risk of dementia or of dementia progression in official statements such as the Dementia Commission, which is hosted by The Lancet. But this slide includes a number of others where it might not have made it onto that official list yet, but they're generally recognized to be sensible things to do to try and maintain the health of your blood vessels, because this is what this is about. If you've got healthy blood vessels, then it's much more likely that your brain is going to be healthy. So we've got a number of ones in the middle about managing your blood pressure. If you've got hypertension, getting it treated. If you've got raised cholesterol, taking tablets to lower your cholesterol. If you have diabetes, then managing your blood sugar. If you've got problems with your eyesight, making sure you've got glasses or correction for the eyesight, and similarly with hearing aids. A number of do's, such as eating a healthy diet, and don'ts, such as not smoking, avoiding excess alcohol, etc., etc. I guess the thing about this is that it's hard to know where to start sometimes, and I think sometimes people are inclined to put their hands up and say it's too hard, and I must have that biscuit. So really what I wanted to do is try and find out a bit more about what our expert panel thinks. So just perhaps go around, what do you think of each of these as perhaps the most important? And maybe if I could start with Katie, who's our general practice representative. What do you think?
Yeah, so I have to confess I've just eaten the biscuit. Now I feel terribly guilty. I think all of these things are actually quite linked. Just personally, what I find most difficult myself is trying to do the right things to de-stress, because actually what I want to do is a lot of the don'ts. So everyone's very busy and, at the end of a day, I know it's difficult. In my practice, I have to say to patients all the time, you need to stop smoking and you need to drink less and you need to eat healthily. And because I know all those things are right, but actually it's practically quite difficult. You know, you've been busy, you've looked after your children, you've been at work, you've done all your house chores, whatever it is you're doing with your day. Everybody feels busy. You're caring for a loved one. You want to kind of do this list, don't you, this list here? And I think it's difficult not to sort of want to either sit and scroll on your phone or watch TV or have a glass of wine or eat some stodgy food. And what I've been trying to do myself recently is exercise more, mixed reviews on how successful that's been. But I think it's about kind of learning how to relax in a different way and trying to put it into a routine. So small bits at a time, you know, go for a walk, even for 15 minutes, to try to sort of de-stress before you sit down and watch a bit of TV. So that's what I try to do with my patients and also try and do for myself.
Do you think it's partly about trying to say that these things are important and maybe trying to give them a bit more priority?
I think people know they're important. I think it's about, I think often people do know what they should be doing and it's just difficult for everybody to do it. Routines, good. I think once people are in routines of doing things and they've been doing it a while, then that's easier. Obviously, there's mixed knowledge out there. But.
So Carmen, you're a neurologist and you specialise particularly in stroke and seeing people with stroke. Which one of these would you put top of the list as, you know, if you could do just one thing for your next patient, what would it be?
Well, I think it's very, very hard to pick one. But however, I think I'm going to pick two, if I am allowed. So I would say that definitely healthy eating and also regularly healthy eating and regular physical activity. I think I would pick those two because they are very powerful in too many aspects. So in keeping us healthy for longer, in keeping us physically independent for longer, in making us able to cope also with unexpected health diseases better. So that's good for our blood vessels, that's good for our heart, that's good for our brain. So, but as I say, it's good to keep us healthy for longer and to make us grow older, healthier. So I will pick those two definitely, but it's hard.
Okay. Terry, what would be your priority?
So, well, where do you start? I guess one of the things that we're increasingly realising is what's good for the heart is also good for the mind. So some of the things on that list there, you probably already knew were good for your health, but for other reasons, like not smoking, trying to get exercise. Something that catches my eye because I realise it's particularly pertinent to my life is about a good sleep routine. We use this phrase sleep hygiene, which I don't really like because it implies that you're slightly dirty if you don't sleep well. But I suspect a lot of people in this room are very guilty of thinking, oh, I'm a bit tired, I should go to bed, but I'm just going to have a look at my phone and I'm just going to answer some of these emails. And I do have to do a little bit of work, so I'll just do that. And the clock ticks and ticks and ticks, and it's starting to get very late at night before you're in bed, and then you're in bed and you haven't really relaxed. Your brain's still very active, you're not getting to sleep. And then a few hours later, the alarm clock goes off and you're back in work. And we're beginning to realise that that's really not good for your brain because sleep is very important for your brain to restore and to get rid of some of the junk that builds up over the day. So if I was going to do one thing in my life, realising that these things are difficult, I would try and get a bit more of a healthier routine with sleep.
Okay. And Donna, can I ask you from your perspective, what do you feel and what do you think is important and what do you think is maybe one of the more difficult ones to achieve?
Well, personally, the important one for me is to stop smoking because, yeah, I still smoke. But the exercise thing can be difficult for a stroke survivor because if they've got a deficit, it's hard for them to maybe do something because their legs or their arms, especially their legs, if they want to go out walking, have been affected. Not so much me, but if I'm really tired, my left side just totally shuts down and I can't walk. Plus, as you get older, other medical conditions come in. So I've got arthritis in my knees from being a swimmer when I was younger. So that prevents me from doing a lot of exercise. I'd love to go to the gym. I've been at the gym and they keep trying to get me to go on the bike, but I can't do the bike because of my knees. And any squats or whatever, again, my knees are killing me. So I would really like to be able to do some exercise. But as I said, because of the deficits, not just me, I've got friends in the stroke world who have got severe deficits, and they find it a struggle to do some exercise. Health eating I do, because I'm constantly trying to lose weight. So I'm always constantly on Weight Watchers or whatever. But the exercise one would be.
Okay, so we're hearing about things that maybe if you can try and build them into your daily routine, it gets a bit easier, and maybe focusing on one thing and then building on the other ones. So perhaps you could just reflect before we finish on if the government, because some of these are government related, things like trying to improve, access to good food, or trying to improve opportunities for people to avoid being isolated, or improve things like educational opportunities, and a number of other things like that really require some political intervention rather than just being something that we as individuals can do. What does the panel think about those? If we had to pressure the government, what would be the one or two things that we might really want to try and get their attention on? Anyone?
I think don't be isolated, because when you first had whatever, you've been diagnosed, you're like a million questions, and you don't know where to go. I found I joined a peer support group, and that was the saving of me. It was people understood what you were talking about and had been through it and could advise you how to cope with certain situations. Or in my situation, it was like going back to work. I advised somebody at the group how to get back to work by using the DWP method. And because I had the sight loss, she told me to self-refer to a vision charity, which I did. And that's how I've ended up with my white stick. So that did not come from NHS. But speaking to people and, getting out and about and doing something. I mean, as everybody knows, I'm a big junior football supporter. So going to the junior football and meeting folk and discussing football, it's great. You come away feeling absolutely wonderful. You don't feel so isolated.
Yep.
So I think my big thing would be getting...
Of course, that's kind of keeping active as well, isn't it? By sort of secondary.
I don't play football. I just go and watch.
No, but even Terry.
So one of the things with the healthy eating message is healthy eating is pretty expensive. So I'd like to see healthy food subsidised. So where I grew up in the south side of Glasgow was near an area called Fergusley Park in Paisley. And very famously in Fergusley Park, you could not get a vegetable. No joke. There were shops. You could get cigarettes, you could get anything, but you could not get fruit and veg. And, there were researchers went to that area and they found it was easier to get heroin than it was to get fruit and veg in that area. So, if that's what you're up against, the healthy eating messages, they ring a bit hollow. So if I could ask the government to do one thing, I think let's try and subsidise healthier eating and maybe tax things like McDonald's.
Okay. Briefly, one other comment?
I totally agree with Terry. And I think we're seeing this huge sort of inequity between people, and food and also exercise. I've got patients who just will say to me, I'll talk about healthy eating, and they'll be like, we can only eat once a day, and so we just fill ourselves up with something sort of stodgy and cheap, because that's all the whole family does. And that's shocking to hear that, when you're not from that background. But also exercise is difficult because it's easy to say, running outside is free. That's not accessible for everybody. Not everybody wants to do that. And I think what we're seeing, don't want to get too political, but we're seeing a lot of services being cut back that are cheap or free to use for people to exercise. And so I think if the government could put some more money into sort of local services that are available for people to use to exercise, then that would be really beneficial.
Okay, thanks very much. So we'll need to wrap up there. But I guess the message is that even small inroads into each of these things can be really helpful. You don't have to go out and run around the block necessarily. Just a bit more activity, just one less cigarette, just a slightly healthier hamburger, et cetera, all can make a difference. I'd just like to draw your attention. There's some useful resources out in the hall that you might want to pick up, where there's a lot of different information that you might want to look at, and also just some more leaflets about healthy approaches to try and maintain your brain health. So anyway, thank you very, very much to the panel. for these comments, and we'll move on to the next session.
Thank you very much, Joanna and panel. And we're going to lose some of them. We're going to keep Donna. Great, thank you. It was nice to finish with lots of ideas, that session, on what we could be doing better. We do, however, as you've heard already, need to be doing more work to find new treatments. And one of the questions we often get asked is, how can I get involved? What can I do to help out? We've got Lucy Sterling now, who I'm going to introduce as one of our old age psychiatrists based in Edinburgh. She's also, I know she's got this in her slide, but she's an Atlantic Fellow, which sounds fantastically exciting as well. But Lucy, and how to get involved in research.
Thanks, Fergus. So I'm just going to talk briefly about different ways that you can get involved in research. We've heard lots of exciting developments about how we can improve brain health for people both who have dementia already and to try and prevent that, all the different opportunities that are available. So how can you get involved? Well, you might think about research overall as just, being involved in research would be being in a trial, taking a drug, or maybe taking an experimental treatment. I'm going to turn to Donna in a little bit and come and ask her some questions about this. But that certainly is an option for some research that you can participate in. So some of those trials might involve trying out a new medicine. It might be, as we heard from Will earlier on, there's some old medicines or medicines that are used for existing things that are being tried for a new purpose. Or it might be trying another type of treatment or technology, so maybe something like a new diet plan or a new app or whatever it might be. And for all those options of trials, you can either participate as somebody in the trial as a participant, or maybe as what we call a control, so someone who's kind of a healthy volunteer who's being there to compare against the people with the condition. The other really important way that is really increasing in popularity at the moment is being involved in what's called patient and public involvement in research. So in the last few years, there's been much more recognition from research funders, from the universities and the NHS and the big charitable research funders, that we shouldn't be doing research about people, sort of on people, without including those people in how we design research, how we run the research, and how we steer the questions that are being looked at. So there's lots of opportunities in Edinburgh and Glasgow, I'm sure, speaking on behalf of my Glasgow colleagues, to be involved in research, both as a participant, but also involved in kind of driving that research forward. And that might be part of giving personal experiences and saying, oh, I had this condition and this is what it was like for me, or it might be talking about actually as a member of the public, this is how that might affect me. And I suppose all these things could also be, they can be kind of discussions, they could be how your experiences, your personal experiences are impacting on it, or how your responsibility for looking after someone else might be relevant. So I'm going to talk to Donna in a second, but before that we have a plug for a research register from the catchily named NHS Research Scotland Neuroprogressive and Dementia Network, which I think is running a competition to find a new name, but that's what it's called at the moment. It's much less catchy than the one that's called Stroke, which it tells you what that one's about. There's a QR code here, so I hope that the people online, this is your moment if you're online to get your phone out. People in the room are going to get given leaflets to take away, which will have this information on as well. But we have a research register in the NRS, Neuroprogressive and Dementia Research Network, where you can give your details, and all that does is it just says, yes, I'm happy to be contacted. It puts you on a register, and then if there are any trials or studies or anything of different types of research coming up, you then get an email or contacted in whatever way you prefer saying, this is a new study that's opening up, and would you be interested? It doesn't mean you commit to anything at all up front, apart from committing to being invited to things. There are also lots of leaflets available outside with all the other different ways of getting involved in research in whatever way suits you. And I'm very quickly going to chat to Donna before we move on to the questions. So this is your call for the last few questions to come in. So Donna, we heard earlier that you've been involved in research yourself. Could you tell us a little bit about what research you were involved with?
Yeah, I get involved basically through Chest, Heart and Stroke Scotland. I support them because they supported me through both my strokes. So they send emails. One of the first ones I did was was a bit kind of what happened. Initially, the day I had my stroke, so I was taken up to the Southern General, and as I was getting the MRI scan, they asked me if they could use my scan for research. So straight away I said yes, and then they asked me to come back later on, and it was the Lucozade test. Now, I detest Lucozade, and I had to drink 1,500 mils of Lucozade, or worst thing I ever did. So, but I don't know what it was for. But anyway, since then I've been involved in what was called the Starfish project. And that was an app in the phone. I loved that app. So talk about getting you active. So basically, it was like a step counter, and you had a fish in a tank, and if you to walk so many steps a day, and if you reach that step count, you got a prize. You to try and fill your fish tank up every week with all your prizes. I was very good at it. So easy to see. Mainly because I was working at the time, and the number of times I was going out the office to have a cigarette, that built up my steps. Anyway, so
it sounds like you've been involved in different types of research. So the MRIs, the scan, being a sort of guinea pig having to drink 1.5 litres of Lucozade, which is an unusual trial, and then also being involved with an app, so a new sort of thing.
Yeah, and now I'm involved in one from Oxford University, no less, and that's to do with statins. So I go up to Cross House Hospital once every 6 months, and I get an injection, and this is to see if these injections can take over for tablets. So I do that.
And would you recommend to other people getting involved in research?
Oh, I always do. Always, definitely. The reason being because, as I mentioned earlier, I was thrombolised, and I thought, well, somebody must have done something with that helped save my life. So I like to give back. So I tell people that, give back, go and help, see what you can do. I mean, it's not just, I've been to a couple of things, but I sign up, I'm straight there first. I don't know why I do it. For like mobility and hand coordination, nothing like that really has affected me, but I'll sign up for it anyway. But I've got a friend who did Rattlers, and she also did the vagus nerve, and that watching her progress through the vagus nerve thing was amazing. I don't think she's on that anymore, but the research into that was just phenomenal.
Great. Well, I think we couldn't hear a more glowing recommendation than from someone who's participated in research yourself. I think we should probably move on to the question bit, shouldn't we? Thanks very much, Donna.
Thank you very much, Lucia and Donna. I'm still trying to work out what the Lucozade trial was. We can't work it out at the moment. Okay, so we have a panel of experts. I'm going to invite Joanna and Terry up to the stage to join you two. And we'll just run with 5 or 6, and I'll just step off the stage. That's fine. So we have, and I'll introduce Katie, you met before. We've been collecting questions from the online and from the written ones, and certainly the ones I've seen are just brilliant questions. Actually, they almost need master's responses. So we'll do our best. We'll do our best to answer them. So.
Okay.
Yeah, sorry.
I've got some questions here.
Why don't you go, Katie?
It's okay. I'll introduce me. So I'm Katie. I'm a GP from Glasgow, and I also do research, and I've done quite a bit of research interested in stroke, which is partly why I was invited along today, and I just also like these events. So this is the Q&A session. Now, we have questions coming in from different places. So people online have sent some questions in, and you're also welcome to raise your hand in the audience, and we have a roving mic that can come to you. And there has been some questions submitted as well, written one, let's see them. Okay, so the challenge here is reading other people's handwriting. So thank goodness none of it's mine. So the first question that I thought we'd start with, I think is for Lucy, but anybody can answer any question if you feel you can. So somebody online has asked, what about learning a new skill, such as a second language or chess? Does this help? So they haven't specified if they mean for sort of primary prevention before dementia kicks in or once someone has dementia, but I think both are interesting. Does anyone want to take that?
I can start, yeah. That's very interesting about the languages, isn't it? Because there is evidence that people who are bilingual, who speak 2 languages all through their life, have a lower risk of getting dementia. I think the evidence for when exactly you learn that second language is a bit less clear, but I'm sure that doing anything that is stimulating your brain, whether that's learning a new language or chess, I think everything that's brain stimulating can be good and protective. Do you want to add anything to that?
The other thing is sometimes things have benefits not in the way you might expect. So you may say, learning chess gets the neurons firing and that helps the brain, but actually learning chess involves going to a chess club and interacting with other people and not being isolated. And I do wonder if some of the benefits you get from doing these things is actually through that interaction with other people, which we know is so good for your brain health.
It might be if you go on your bicycle, then you also get the benefit of some physical activity. Yeah. But more seriously, I think it's the whole thing. If you don't use it, you lose it. And trying to do something positive like learning a language or maybe taking up a new craft or whatever that might involve more manual dexterity or it might involve more, sort of cognitive processes, I think it's all good. I don't think there's any evidence that any of these are bad for you unless it's something that's potentially risky or harmful in that way.
That's great, thank you. And I've got a question for Donna, if that's okay. So the person says to Willie and Donna, both thank you for your talks. So learning and understanding your diagnosis must have been very challenging and confusing. Have you found the experience of bringing others, like friends, loved ones, other professionals, on board with you difficult? So what they mean by that is helping others to understand and support, especially with your symptoms not necessarily being completely typical or expected. Do you want the roving mic?
That's all right. So I used to be a journalist, and when I was a journalist, I used Twitter a lot. And when I started my diagnostic journey, I went back on Twitter, and I said, I've just been off to Livingston Hospital today, and I've had a brain scan. And I was astonished by the positive reaction I got from people going, well, we've never heard of anybody talking about this before. Tell us more. So I took a very conscious decision to be open and honest about having what turned out to be a series of brain scans, having a lumbar puncture, which I don't recommend to anybody, particularly if they can't find the cerebral spinal fluid on the first go. And actually, I've had nothing but positive responses from people. I have had quite a number of people go, we're really surprised at how open you are about having dementia, as if dementia is something one should be ashamed of, which I think is very sad. But I do think that in the public's mind, dementia is kind of where cancer was 40 years ago. And you might have noticed around Scotland a whole series of posters launched this week by the Scottish Government to try and bust the stigma. I think the more we can be open and honest, then the better.
Well, for me, if you hadn't already gathered, I like to talk. And I like to bring humour into things as well. And being only 46 with my first stroke, everybody was shocked at that. I never knew you could have a stroke so young. And then as I was progressing through my journey, I don't like the phrase stroke journey, that I came across more younger people. I'm very open about it. I would tell anybody what happened. Sometimes I feel they get a bit bored with the whole long story about what happened on the day I had my stroke. But yeah, everybody's always quite interested and very positive about it. And I think, as I said, because I like to bring a bit of humour into it. There's nothing funny about it, but at the same time, it makes them feel a bit better. I would rather they felt better. And then folk look at me and say, you've never had a stroke. And I went, too, actually. So, yeah, I've had nothing but positivity from friends and medics as well. So.
Okay, thanks both. There's been a few questions about screening. So people have asked if there is any way to screen for dementia in the form of scans mainly. Is there any hope for that happening in the future? Is there any benefit in that? Joanna, maybe?
Well, I'll respond first. So yes, that's been the subject of large amount of research. In fact, several people on the panel have, deeply involved in that. Will Whiteley, for example, is leading a large study trying to see if we can detect earlier signs using routinely, people when somebody has a routine scan for something. I guess the thing about scanning is that it's quite expensive, and the problem in the UK is that we've got a lot of people that need scanning because they've already got a disease, for multiple sclerosis or a brain tumor, or they've just had a stroke or whatever it might be. And in order to extend it, to make it available to then be able to screen what you might call, otherwise healthy people who haven't yet had an actual disease is quite challenging because we just haven't really got big resources. So there's also a lot of research going on trying to look at other things like blood tests. There's been a whole series of items in the news in the last year or so about this, that, and the next blood test for Alzheimer's disease. We haven't got anything quite like that yet for the more vascular side of cognitive impairment and dementia. But, there's a lot of work going on in that space. But, there's probably other ways as well.
I guess where thinking has changed in the last decade or so is we now recognise that the thing we see as dementia is the end of a process that maybe began 10, 20, 30 years beforehand. And as we start to understand that biology, it does open up the opportunity that you can look to see, is that biological process happening in middle age that might have implications for when you're older. The problem up till now is that to really look at that, you had to have some of the tests that Willie spoke about, having a needle put into your back to pull out spinal fluid, or having to have a very expensive scan that sort of makes you glow in the dark afterwards because of all the radiation you get. Where things are changing, what I think is really exciting is right now there are trials and studies of blood tests that potentially give you that same information, but you don't need a needle in the back, you don't need to be in a long scan, or some of them are even just a finger prick and a drop of blood on a little bit of paper. Now, important to say, they're still at the phase of being researched. They're not something that will be available in your GP or your hospital right now, but I can see they will become available in the next few years' time.
Okay, thank you. So this is a question from an audience member. I don't think it's going to be that easy to answer, but it's an important point. So they've said, based on what we've heard, for example, symptoms that surprise both the individuals and health professionals, such as visual disturbances, and how hard the health system can be to navigate, for example, seeing a GP, how do you propose people continue to champion for themselves? So I know that's not easy, but...
Well, I guess a thing that I would say is you're not alone. If you are someone that has had a stroke, or someone that's had a recent diagnosis of dementia, or a loved one has had a diagnosis of dementia, there are support groups out there. I mean, sure, you'll get support from NHS services, but we have really great support from third sector services like the Stroke Association, Chest, Heart and Stroke, Alzheimer's Scotland. They have really good resources online. They have helplines that allow you to chat to people, and they can connect you with other people that are probably going through the same thing. And going back to, I think, a recurring theme of today is, we have a leaflet as well, I'm being reminded. One of the recurring themes today is about how damaging isolation can be for your brain health. And I think that's particularly true if you've just had a very important diagnosis that you can't share with people. So going to those third sector organisations, connecting with other people, I think that's really important.
Okay, thank you, Donna.
With my first diagnosis, now, as I said, I was only 46, and I've always had an interest in medicine throughout my life. I loved anything medical. So we come under medicine for the elderly, which I was quite shocked about. So when I was going back for my outpatients appointments with the consultant, I asked him if I could see my brain scans, and he was quite taken aback. But I think because the older generation nowadays is, are always told to revere medical staff, so they're frightened to ask questions. But because I came along and I had a wee bit, I thought I had a bit of medical knowledge, and I started to ask questions, I was quite surprised at how taken aback it was. But advocate for yourself, yeah. And also, speaking about isolation, Chest, Heart and Stroke Scotland run a befriending service, and I've actually just signed up to be a volunteer for that. Surprise, surprise. So it's about people who have already lived the experience, speaking to like new survivors, so we can then advise them, and then we're getting training on how to, where to refer them for help. So, and I'm quite sure that other dementia charities must have the same thing.
Could I just
Yeah.
add to that? Because I think it's very easy when you're anyone, this is anyone, whether you're medical or not medical, but you're in the position of being on the wrong side of the stethoscope. First of all, you often have very little time, GP 10-minute, 8-minute, whatever appointment. If you're not feeling great, you may not have everything right at the front of your mind. It's often friends and relatives who will know you very well. I think it can be extremely helpful if you always go to an appointment with somebody who knows you, because there are many examples where, for example, people do all sorts of established tests of cognition, remember 5 words and put the square peg in the round hole and join up the dots and, all this kind of thing. But in the end, they are not perfect. And as we've heard today about all the different range of symptoms which can present, some of those are just not captured in any of these very standard tests. And as we also heard, certain aspects of, the medical silo system can get very focused on, one particular symptom and forget about the other symptoms. And so it's actually really important that you do say, but we've also noticed this is not normal, and not get the brush off. And I don't think there's any way around this, unfortunately. I think we do have to sort of speak up, and even if it feels like you're making a pest of yourself, you should feel to do it, because there is help. There are things, even if there isn't some magic pill, there are many other things which can help in daily life, or you can be put in touch with, and you don't want to miss out on that. I just think it's really important.
Yeah, and just on a practical level, I know it's hard to see a GP. I'm the GP here, so I don't want to get rotten eggs thrown at me. But, it is difficult to see a GP just now. On a practical level, things like asking for a double appointment, it will depend on the setup of your practice, but can be very useful. And trying to see the same GP if you can. Now, that's sometimes with your control. Again, it completely depends on the way your practice is set up. But asking if you can see the same person again can be very helpful, but I do appreciate the challenges that are met, but these things can help. Okay, so we have a few questions that have asked about the risk of developing dementia if a relative has it. So, for example, someone has said, my mother has early onset dementia. Is there a risk I could develop this too? Who would like to?
I suppose it was tricky, answering individual questions about individual people in this kind of setting, but there are some dementias that can be hereditary and can run in families. And that's something that a doctor who's assessing memory and dementia would always ask about is, has anyone else in the family had it? And is there anything that runs in the family? So there is a possibility, but we can't really comment on individual cases in this sort of scenario. I suppose the things that all those healthy living and healthy lifestyle things that we were talking about earlier are still important for people, regardless of your background and family background, that you can still change things by making changes yourself.
There are some dementias that very much run in families. There is a genetic component to a lot of other dementias, but it's just one component, and it's not inevitable. For example, if you have a mum or a dad that had dementia, that you're going to get dementia. And I wouldn't want people to be nihilistic and think, oh, well, my mum had dementia, so I'm bound to get it, because that's not the case. And, all of those healthy lifestyle messages that we've been trying to get across, if anything, are more important in that situation.
Okay, that's great. Thank you very much to the panel. I think that's us wrapping up now. Okay, thanks very much.
Thank you, Katie, and to the panel. That was really interesting. Thank you to you for the questions that we will get through the ones we didn't get to. I'd like to call upon Joanna Wardlaw to finish off the session just now. Thank you, Joanna.
Well, thank you very much for coming. I hope that you've found it useful. We've certainly enjoyed very much putting it together. I guess the main message, if there's one message that you could take away, it is that although there may not be any magic bullet pill or magic scan that will tell you that you're going to get dementia in 10 years' time or whatever, there's actually a huge amount that you can do just on a daily basis to try and minimize your risk. And these are all things which, you know, we would all encourage all of us to be trying to do. You know, and sort of, I mean, just to give you one example, not from dementia or stroke, but some years ago, Scotland banned smoking in public places. And because we have very organised central health statistics, it's possible to track quite subtle changes in and minute changes in health practice and the impact that that has on the population. And within even a few days of this ban coming into force, it was already possible to measure a reduction in the number of people who were going to A&E departments with heart attacks. So everything that we've talked about today, even things in moderation, can actually have quite a big effect. So don't feel it's all hopeless and, you know, there's no chance, and et cetera, et cetera. It's really important. There is information. We've put together a leaflet, which I've mentioned several times already, but it's full of information about a number of organizations that do things like put you in touch with others that have had a similar experience or point you to where you can get more information, either to help or to get information about diagnosis, information about things that you can do to try and maintain a healthy lifestyle, some bits of pieces about symptoms, because they are much more varied than might have been thought before. I'd also like to highlight the Brain Health Arc, which Terry Quinn runs. It also has a number of useful resources, and we haven't been able to take absolutely every question this afternoon, but what we will do is collate all the questions that we've received and put answers to them, and those will be put up on the Brain Health website in a few weeks' time. You can also get in touch with us through the RSE if you have questions. Very happy to take questions, answer anything that might come up in further thought afterwards. So just again to thank you all for coming and to thank you for participating. The Royal Society of Edinburgh is also running a number of other public events as part of this Curious Festival of Knowledge. And there is information in the foyer, and there's also information online and QR codes that you can scan to look at what else they're running, which might also be of interest. So I'd just like to thank everybody, in particular the panel members, in particular Willie and Donna for coming and sharing their stories, so important, and all you for coming. So thank you very much. There will be people out in the foyer if you want to ask questions after or